Hello again, everyone. Today I'm going to be talking about the role of the liver and metabolism. This is listed as 2 lectures, but I'll be giving it in just one lecture here. An outline for today, I'm just going to have an introduction and structure of the liver, talk about liver and metabolism and focusing mainly on both carbohydrate and protein metabolism. Then we'll talk a little bit about heme, what that is and how it's synthesized. We'll talk about drug metabolism, alcohol metabolism, some functional tests of the liver that are clinically relevant, and some liver disorders that are clinically relevant. First, let's talk about the liver and at a high level. So the liver, the central role in metabolism of the liver is due to where it's placed anatomically in our bodies, as well as its biochemical function. The important properties of the liver include that all materials that we ingest into our body are filtered through the liver. It also has synthetic and catabolic functions, which we'll talk about some of those today. Things like regulating carbohydrate and lipid metabolism, amino acid metabolism, synthesis and breakdown of proteins, storage of vitamins and metals, and as well as metabolism of non-natural substances such as drugs. It also has excretory functions. So the metabolic waste products are secreted through this branching system of ducts known as the biliary tree, which in turn drains into the small intestine, and then these constituents are ultimately excreted in the feces. So obviously the liver is an important organ in our body. It has a substantial reserve metabolic capacity, so when people have mild liver disease, you typically have no outward symptoms, and it's typically only detected as biochemical changes in the blood, and we'll talk about some of those later on. Whereas severe liver disease, you can end up with things like yellow pigmentation of the skin, you can have bruise easily, you may bleed easier and more profusely, you can have the abdomen distended with fluid, and you may lead to confusion or even unconsciousness. Here's a picture of some of those clinical features with severe liver disease. As I mentioned, you can end up with yellow pigmentation, jaundice, things like that, bruises. But as you can see by this, the clinical features show up in different systems because the liver is tied to so many systems in our body. The main functions of the liver, the hepatic cells are shown here, and we can shown the markers of impairment can be found in the plasma. So for example, if one of the main functions of the liver is metabolism of heme. When this is malfunctioning, you see higher levels of bilirubin in plasma. Carbohydrate synthesis is another, carbohydrate metabolism is another function. You can see higher levels of glucose in the plasma when this is disturbed. Protein synthesis and protein breakdown. For protein synthesis, you can see higher levels of albumin, prothrombin time. For protein breakdown, you can see higher levels of ammonia and urea in the plasma. Lipid metabolism, if that's impaired, you can see higher levels of cholesterol and triglycerides. If drug metabolism is messed up in your liver, you can see higher levels of the drug or higher levels of the drug at halftime. And another function being bile acid metabolism, and obviously then you'd see higher levels of bile acid in your plasma. Here's a picture of the liver structure. It is the largest solid organ in our body. It's about 1.5 kilograms in adults. The blood flow, about 75% of it comes from the portal vein, which is shown here. This arises in the intestine. Blood leaving enters through the venous system through the hepatic vein, the central hepatic vein shown here. And then the biliary components, the gallbladder and the bile duct, are shown here. The structure of the liver facilitates exchange of metabolites between liver cells and the plasma. That's a general introduction. Now let's talk about the liver metabolism of carbohydrates and proteins. For carbohydrates, the liver plays a central role in glucose metabolism. It maintains a circulating concentration of glucose, and this concentration depends on the ability to store a supply of glucose in the form of glycogen, which we've talked about in the past, as well as the synthesis of glucose during gluconeogenesis, which is also covered in previous lectures. One of the main enzymes involved in carbohydrate metabolism in the liver is glucose 6-phosphatase. It's an enzyme that permits the release of free glucose to the blood by hydrolysis of glucose 6-phosphate, hydrolysis of the phosphate bond to form phosphate and free glucose. So the liver obviously has this activity and it stores glycogen. The liver releases about 9 grams of glucose per hour when we're fasting, and in the feeding state, glucose production is suppressed by insulin and higher uptake of glucose and thus conversion to glycogen in the liver by a protein called the GLUT2 transporter. This is due to its high Km. The muscle itself stores more glycogen than the liver. It has no glucose 6-phosphatase activity, so muscles cannot directly contribute to glucose in the blood, whereas in comparison to the kidney, it has both enzymes that can make glucose as well as glucose 6-phosphatase activities, but they are much lower than the liver, and kidneys do not store glycogen. So liver is the main organ that releases glucose into the blood, mainly through this glucose 6-phosphatase enzyme. Let's talk a little bit about protein metabolism by the liver. The majority of plasma proteins are actually made in the liver. So albumin, which is composed a large part of our proteins in our plasma, coagulation factors for our blood, plasma alpha and beta globulins, as well as acute phase proteins, which we'll talk about. Acute phase proteins are relevant to what's called the acute phase response, which is a systemic change which occurs in response to infection or inflammation. So these acute phase proteins are proteins with a normal plasma concentration, changing by more than 25% within a week of inflammatory or infection. The production of these proteins is stimulated by pro-inflammatory cytokines that are released by macrophages such as interleukin-1, TNF-alpha, and interleukin-6. Binding proteins, opsonins such as C-reactive protein, bind to macromolecules released by damaged tissue or infective agents and promote their phagocytosis. So all of these are acute phase proteins that can raise in concentration or lower in concentration within when we get some sort of inflammatory or an infective insult. As I mentioned, one of these proteins is C-reactive protein. It's one of the major components of this acute phase response. So it's synthesized in the liver. Its structure is composed of 5 polypeptide subunits, molecular weights around 130 kilodaltons. And normally in serum, it's less than 1 mg per mil. But it can increase dramatically in concentration after an infection, which is shown here. You can also get increased concentration after surgery, as another example. So people use C-reactive protein as a measurement of acute phase proteins. It gives you useful information about both the progression of a disease as well as a response to a treatment. The changes in the serum concentration of the CRP are quantitatively the most marked of all the acute phase proteins. It's very easy to measure, and as you can see, it has a pretty big dynamic range, so it's a good indicator for, again, progress for disease and response to treatment. Some clinical conditions that are associated with abnormal concentrations of liver-produced proteins that we measure in the plasma are shown on this slide. For example, genetic deficiency of alpha-1 antitrypsin presents in infancy as liver disease or in adulthood as lung disease. Genetic deficiencies of a protein called ceruloplasmin, which is a copper-carrying and iron oxidizing protein. It can lead to genetic deficiencies in this protein can lead to a condition called Wilson's disease, which is associated with damage to the liver and the central nervous system. Basically what happens is iron can't be metabolized correctly, and copper deficiency produces anemia. Liver cancer can be associated with a particular high plasma concentration of alpha-fetoprotein. This is because this protein is synthesized at a high rate during liver cell proliferation. That was a little bit about proteins in the liver. Let's talk about how proteins are degraded in the liver. So plasma proteins and membrane proteins are endocytosed and then hydrolyzed by acid proteases within intracellular organelles known as lysosomes, which you may have talked about in previous lectures. In contrast to plasma proteins, intracellular proteins are degraded within the proteasome, which I have talked about in some of my previous lectures. And I've also talked about ubiquitin marking intracellular proteins for proteasomal degradation. So there's a slight difference between intracellular proteins and plasma proteins, which in the way they're degraded. The urea cycle, which I believe you talked about in some of your other lectures as well, and ammonia. The urea cycle is essential for removing nitrogen that's generated by amino acid metabolism. So when you break down amino acids, you generate ammonia or ammonium ions, and most of this is detoxified at the site of its formation by amidation of glutamate to glutamine, which is mainly derived from muscle, and again is used as an energy source, can be used as an energy source. The remaining nitrogen enters the portal vein either as ammonia or alanine, both of which are used by the liver for the synthesis of urea. Our body has to get rid of ammonia because it's toxic, particularly to the central nervous system. And when you have impaired clearance of ammonia, it can cause brain damage. That's the liver and metabolism. Let's talk a little bit about heme, how it's related to the liver, what it is, how it's made, and how it's metabolized. Heme is a constituent of hemoglobin, as well as myoglobin and cytochromes, which cytochromes we talked about when we talked about oxidative phosphorylation. It's made by most of the cells in the body. The heme itself is the O2 binding moiety common to myoglobin and hemoglobin. Here's the structure of heme. The liver is the main synthesis, is the main provider of heme, although other cells can make it. Red blood cells also makes a lot of heme as well. Porphyrias is a disease that results from defective heme synthesis, and it can be caused by different enzymes in the pathway. If you have enzymes screwed up in the pathway, that can all lead to this same disease. Here's how the synthesis works, and we'll step through this a little bit one at a time. Again, I don't expect you guys to memorize this entire pathway, but I'll highlight a couple things that are of interest. In this first step, so just to orient you, this is the mitochondrion of in liver cells, for example. This could be in other cells as well. And then here's the cytosol of the liver cell, for example. In the first step, you get glycine and succinyl-CoA condensed to form 5-ALA, shown by this step here. It's catalyzed by an enzyme called 5-ALA synthase, which again is located in the mitochondria. This is the rate-limiting step in heme synthesis. So once you get past this step, it's kind of going full throttle. In the next step, in the cytosol, you get 2 molecules of 5-LA, so you get 2 molecules of 5-LA, move into the cytosol. They condense to form a molecule containing a pyrrole ring, this PGB, which is shown here. And then you get 4 PGB molecules combined to form a linear compound, which ultimately cyclizes to form this beast here. So again, I don't expect you to memorize these structures at all. This ALA synthase would be an important enzyme. But then the next step, what happens is in the final stages, you again go back into the mitochondria where you get a series of decarboxylations and oxidation of side chains to yield more complex ring structures. And then in the final stage, iron 2 is added by an enzyme called furochelatase to form this heme. So you can see you go in and out of the mitochondria to form a more complex structure and ultimately this heme structure shown here. And then, this binds to things like hemoglobin and myoglobin. Once you form heme, it actually controls the synthesis by inhibiting this initial enzyme. So if, again, there's a lot of complexity going on this slide, but this is the most critical point here is this ALA synthase is really the critical beginning step, and then the end product heme inhibits this to slow down synthesis essentially. So our body's telling us, hey, we have too much heme. It inhibits this enzyme to slow the whole process down. Heme can break down to form a product called bilirubin. So here's what that looks like. The ring structure is cleaved by something called heme oxygenase, and then to form biliveridin, and then it's biliveridin reductase then forms bilirubin. This cycle, in addition to the demonstration of the potent antioxidant activity of bilirubin, has led to the hypothesis that bilirubin's main physiological role is a cellular antioxidant. So bilirubin can actually be a good molecule in our body to act as an antioxidant. The bilirubin itself is excreted in the bile in the urine, and elevated levels can indicate certain diseases, as we alluded to earlier in the lecture. It's responsible for yellow color in bruises, urine, and the yellow discoloration in jaundice. 75% of all bilirubin is derived from hemoglobin of old red blood cells, shown here. You can get breakdown of heme into bilirubin. You can have unconjugated bilirubin complex with albumin. It can be phagocytosed by mononuclear cells in the spleen, bone marrow, and liver. Normal daily loads are about 250 to 350 milligrams in adults. Biliveridin, the precursor to bilirubin, is soluble, whereas bilirubin is not. So it has to be further metabolized. So it can be transported by a carrier protein such as albumin. It can be complex with glucuronic acid to increase its hydrophilicity to make it more soluble. The conjugated bilirubin in the gut is then broken down by bacteria. It can be formed into a molecule called stercobilin, which is responsible for the color in feces. Some of it can be reabsorbed and then resecreted by the liver or kidneys as well. That's heme and its breakdown product bilirubin. Let's talk about one of the most important functions of the liver when we're thinking about medicinal biochemistry, and that's drug metabolism. Most drugs are metabolized by the liver, so these liver enzymes can have low substrate specificities, allowing reactions with drugs. So even though they may not interact with their main substrate, may be something else, it's fairly inspecific or non-specific for that substrate and allowing it to react with other types of drugs that may look like it. One of the main functions of the liver is to increase the hydrophilicity of drugs, and therefore they can be secreted easier through the excretory system. The metabolites that are produced by these reactions are less pharmacologically active than the drug itself. That is sort of a general trend of drug breakdowns. There are also some drugs that are made in inactive forms that take advantage of liver enzymes. So they're made as a prodrug and then they're converted to their active form as a result of some of the processing in the liver. There's two general phases where this metabolism of drugs occurs in the liver. Phase 1 is the addition of polar groups by, like, for example, a hydroxyl group. And these are mediated by cytochrome P450 enzymes. You'll see it abbreviated as CYP. Phase 2 is conjugation. So the drugs are then partially metabolized drugs are then conjugated. It's mediated by enzymes in the cytoplasm. You can get sulfitation, acetylation, or methylation, for example. The active site of P450 enzymes contain a heme iron center, so this heme comes into play with these enzymes as well. And this is important for the oxidation of organic substrates. You can see the process here. I'm not going to dwell on it, but essentially the drug comes in, interacts with the P450 enzyme, and you can see the metabolism process begins, essentially ending with the hydroxylated form of the drug, which can be further processed in phase 2. These P450 enzymes, again, are heme-containing. They co-localize with reduced NADPH. They are present in the endoplasmic reticulum in the liver. And most metabolism of these enzymes takes place in the liver, but there are a small amount of these enzymes in the epithelium and the small intestine as well. There are 12 P450 gene families. 3 of them are responsible for most of the phase 1 drug metabolism, CYP1, 2, and 3. Synthesis of these cytochromes that are paired with these P450 enzymes is induced by certain drugs and their xenobiotic agents. However, drugs or agents that form relatively stable complex with cytochrome P450 inhibit the metabolism of other drugs that are normally substrates for that cytochrome. So that's kind of a mouthful, but here's an example. So CYP1 metabolizes caffeine, but it can be inhibited by a molecule called naringin, which is in grapefruit juice, or by the antibiotic ciprofloxacin. So this is where these drug interactions come into play. Another example would be the drug ritonavir, which reduces CYP3A metabolism of HIV drugs. So again, these are where our drug interaction warnings come into play due to these, a lot due to what's going on with these P450 enzymes. You can get allelic variation as well that can affect the catalytic activity of P450 enzymes. So this can be important for the course of therapy after organ transplantation, for example. The breakdown of some drugs can lead to toxicity in some cases due to production of a toxic metabolite. For example, acetaminophen is broken down. If you have too much of it, you can get action of cytochrome P450 to form this NABQI molecule, and you can form free radicals ultimately and get some cytotoxicity there. So you don't want too much of these drugs because you can build up some metabolites that are toxic in some cases. Obviously, we know acetaminophen is a painkiller. As I said, if you take it at normal therapeutic doses, it can be conjugated with glucuronic acid or sulfate, which can be excreted by the kidneys, no problem. Whereas this overdose can lead to this free radical mediated peroxidation, and then these free radicals can lead to messing up membrane lipids and ultimately leading to damage of liver cells. That's drug metabolism. Alcohol metabolism is also important in the liver. Liver disease, one liver disease can be from alcohol excess. If you have an excess intake of ethyl alcohol, this disease remains the most common cause of liver disease in the Western world. It can lead to liver inflammation, abnormal retention of fats, excess fibrous connective tissue, psoriasis, and ultimately liver failure if you have way too much of it. What happens here is ethanol is oxidized in the liver by an enzyme called alcohol dehydrogenase. From that, you form a molecule called acetaldehyde, which is in turn oxidized by acetaldehyde dehydrogenase to acetate. The liver damage in patients who abuse alcohol can arise from the toxicity of this acetaldehyde here, which can form a shift base adducts with other macromolecule. So the toxicity is mainly due to a buildup of acetaldehyde. Nicotinamide NAD plus is a cofactor for both of these, as you can see. The increased ratio of NADH to NAD can alter the redox potential of the liver, which inhibits oxidation of lactate to pyruvate. So what happens there, you can lead to lactic acid acidosis and hypoglycemia, essentially low blood sugar, since pyruvate is a substrate for gluconeogenesis, which you learned about, as well as triglyceride synthesis due to beta oxidation inhibition. So a lot of this toxicity can also be due to essentially requiring too much NAD. So you essentially using up your NAD and creating an NADH, and so you make an imbalance of NADH to NAD, leading to these downstream effects. So there's two things involved here: the acetaldehyde buildup, and then the reduced ratio of NAD or increased ratio of NADH to NAD. There's also other effects. So you can have ethanol consumption can lead to messing up the ubiquitin system of protein degradation. This leads to obviously decrease in proteasome activity, and it deregulates the hepatocyte signaling system. And then you can have increased reactive oxygen species. The alcohol dehydrogenase and ALDH that I showed on the last slide, you can have polymorphisms of these, and you can have a potential inherited basis of susceptibility to alcoholism and alcoholic liver disease, because these are such important enzymes in degradation of alcohol. That's metabolism. We're going to end the lecture here on talking about liver functional test and some of the liver disorders that we haven't gone over yet. Liver function, some biochemical liver functional tests. They're often what you see as a panel of measurements on the plasma or serum specimens. It's usually called the liver functional test. It includes measurements of bilirubin, albumin, aspartate aminotransferase, and alanine aminotransferase, alkaline phosphatase, glutamyl transferase. These are all activities of enzymes that are made in the liver, or breakdown of heme in the case of bilirubin, and they could be good markers of liver disease. Prothrombin synthesis is also a good indicator of liver function. I mentioned aspartate aminotransferase and alanine aminotransamides. These are involved in the conversion of amino acids and keto acids and are required for the metabolism of nitrogen and carbohydrates. These enzymes are both located in the mitochondria, and ALT is also found in the cytoplasm as well. But the serum activity of ALT and AST increases when you have liver disease. So these are good measures of liver disease. I'm going to end here with a couple talking about some liver disorders. I alluded to a few of the genetic-based liver disorders. There are hereditary hemochromatosis disorders. These are iron metabolism disorders and overabsorption of iron from the gut. It's due to a mutation in the HFE transmembrane protein, which modulates iron uptake. Wilson's disease is which I alluded to, is an excess copper deposition in the liver, and this can be due to different genetic mutations. Gilbert syndrome is another liver disorder. It's common, but it's not very harmful. It can lead to jaundice. Another disease called Crigler-Najjar syndrome is rare, but it can be fatal. This is due to severe unconjugated hyperbilirubin. There are different classifications of liver disorders. When we talk about inflammation diseases of the liver, this is what's referred to as hepatitis. The name comes from the fact that it can be caused by viruses such as hepatitis A, B, or C, but it can also be due to toxicity from alcohol and drugs like acetaminophen. Psoriasis is a chronic hepatitis disorder, so chronic inflammation is known as psoriasis. Hepatic failure is from when the biochemical function of the liver is completely, severely, or fatally compromised. Cholestatic disease is when you have obstruction of the biliary, and then obviously jaundice, which we've talked about, is the yellow color. Just to go a little bit more detail about jaundice, it's clinically obvious when the concentrations of plasma bilirubin are over 50 micromolar in the plasma. So you get this yellowing of the skin. When we talk about hyperbilirubinemia, it's the result of an imbalance between how much of this is produced versus how much it's excreted. There are three main causes: prehepatic, which is increased production of bilirubin; intrahepatic, which is impaired hepatic uptake, conjugation, or secretion of bilirubin; or posthepatic, where you just have obstruction of biliary drainage. Going into a little bit more detail about that, prehepatic jaundice, you can have excess production of bilirubin as a result of hemolysis, so red blood cells lysing, or due to a genetic abnormality in the hepatic uptake of unconjugated bilirubin. When you have hemolysis, it's often the result of either immune disease, the presence of structurally abnormal red blood cells, or the breakdown of blood. Intrahepatic jaundice, this again reflects sort of a generalized hepatic dysfunction. It's common in babies due to immaturity of the enzymes controlling bilirubin conjugation to the more soluble and forms that can be excreted from the body. If you have way too much of unconjugated bilirubin, it can be very toxic. The jaundice itself in babies is treated with a blue-white light. The reason for this is it isomerizes bilirubin to more soluble forms, and then it can be removed from the body. You can also do a blood transfusion in more severe cases. Posthepatic jaundice is again caused by an obstruction of the biliary tree. So what happens here is the plasma bilirubin is conjugated and other biliary metabolites such as bile acids accumulate in the plasma, and you get incomplete, and in some cases you can get complete obstruction where some of the markers in urine are completely absent, and then you have basically no renal excretion of these reabsorbed metabolites. But essentially, the posthepatic jaundice is due to this, due to the obstruction in the biliary tree. Okay, that's all for today's lecture. I went into some detail on some of these things, but just to bring it back up a level for you guys as far as what would be on the exam. I talked about some of the main functions of the liver, so obviously it's important to know those, what the main functions are. It was covered on just a handful of slides there. The major components of the liver, I'm not going to draw any diagrams of the liver on there, but the main components of the liver are important to know. The diseases and the clinical features and the markers of liver disorders are important to know. Some of the genetic diseases I talked about the drug-induced diseases, the toxicity with acetaminophen is important to know, and how alcohol is metabolized. And then the three types of jaundice that I just talked about. What is the enzyme glucose 6-phosphate? Why is it important? It's an enzyme that releases glucose into the blood. It's a liver enzyme that does that. What are acute phase proteins? One of them in particular, CRP, that I talked about. What are these important markers for? How the urea cycle relates to liver metabolism. And again, at a high level, how drugs are metabolized, particularly phase 1 and phase 2 at a high level, what that metabolism looks like. And then the liver biochemical tests, I went over some of those briefly, what those are used for, and why they're important. So that's it for today. Appreciate your attention, and I will see you guys next time.